recording? Okay, right, I think we are recording. Yeah, as far as I understand, it's recording. Okay, great. For those who don't know me, my name is Andrea Icely. I'm going to cover quickly the concept of SCAPE, which is in emergency medicine, sympathetic crashing acute pulmonary edema. I'm just going to go through some of the following things. Sorry, I think my computer's a little bit slow. My apologies. 1 second. I'm just going to stop sharing for 1 second, and then I'm just going to see if this is a technical issue. Okay. All right. I think we're back in business. Okay. All right. Sorry about that. Okay. So basically for SCAPE, I'm going to cover what is some background information, including the pathophysiology, how it presents, including the history and exam that we will come across on patients that we might interact with in the ED, the investigations that are most pertinent, management, and then a quick summary, as well as my references at the end. So what is SCAPE? So it's quite a newish topic, title, mostly specific to emergency medicine and critical care terminology. It used to be known as flash pulmonary edema. But SCAPE as a term tends to cover a little bit, it covers more of the physiology, so it's a bit more intuitive in understanding that it's a sympathetic driven process, like the sympathetic nervous system is driving it, which we'll get to. It falls under the umbrella of cardiogenic pulmonary edema. So FOSPE as well, FOSPE, is a newish term, also in emergency medicine and critical care. It's essentially what we used to believe was like the your typical cardiogenic pulmonary edema, which I'll come to in a table later, where the two are compared. And FOSPE is more of a chronic, gradual onset, and SCAPE is, as the C denotes, a crashing onset of symptoms. So the hallmark feature that's most important to take away is that it's due to a pathologically elevated afterload caused by severe vasoconstriction of the systemic blood vessels and hypertension. Usually they're severely hypertensive. And unlike what we used to understand as kind of FOSPE or cardiogenic chronic pulmonary edema, the fluid status is not irrelevant to SCAPE. Patients can be hyper or totally euvolemic. The issue is that it's a maldistribution of fluid into the lungs, creating a relative overload, but only in the pulmonary vasculature. So this table is a little bit wordy, but basically I've highlighted the points that I think are important to remember with SCAPE, that it's a very rapid onset illness, that it's the physiological issue here is afterload. And I'll come to that, exactly the afterload component of cardiac output. That volume status is not really important, that patients are typically severely hypertensive, and that systemic congestion is often absent, and if it is present, it's usually because of a combination of the two rather than just SCAPE on its own. That is where the difficulty can lie, is that the patients can often present with the combination of two processes going on. But for the sake of just looking at SCAPE, it's a summary of its pathophysiology is that essentially a patient there will be a trigger that makes the patient feel unwell, dyspneic, that induces a stress response, release of catecholamines, adrenaline primarily, causing sympathetic activation, vasoconstriction widespread. This increases the afterload of the heart, which worsens the cardiac, or puts more stress on cardiac function, worsening any element of cardiac failure that may already be there. This then causes a backtracking of pressures and fluid accumulating into the lungs, causing pulmonary edema. That then further impairs lung function, oxygenation, further causing the patient to feel unwell, dyspneic, and that whole stress cycle kind of continues. And this cycle can very quickly spiral into a very unwell, distressed patient, and is usually why it's a matter of hours usually that patients are unwell before they present or do quite badly. There's also then the sympathetic vasoconstriction of the venous system, shifting blood out of your splanchnic veins and into your lungs, just adding to the accumulation of fluid in the lungs. So quickly just looking at the cardiac, quickly looking at cardiac output, understanding that it's your heart rate and stroke volume, and that stroke volume is then can be understood as consisting of three components: the preload, contractility, and afterload. So in SCAPE, afterload is the component of stroke volume that we're most interested in. And on the left there, where I have the numbers, number 3, where afterload says that it's proportional to the systemic blood pressure, then it's quite easy to understand that the higher the blood pressure, more hypertensive a patient is, the higher the afterload stress on the heart. And then this comes back to the cycle that I've previously mentioned, and then understanding what causes an increase in the afterload. And that in this case is driven by your autonomic nervous system, specifically your fight or flight system. This table, again, also a little bit wordy, but it's basically just comparing the parasympathetic and sympathetic nervous pathways. But I've highlighted what I think is most important here is that the sympathetic influence of a rise in heart rate and the release of catecholamines is the main driving components that the sympathetic nervous system, kind of the role it has to play in SCAPE. And then this is just a picture that I thought was quite a nice summary to show that sympathetic tone on the peripheral vasculature is always there, that with stimulation of the sympathetic nervous system, it's a higher firing of sympathetic nervous signals to those blood vessels to cause them to vasoconstrict. And then with the reduction of sympathetic tone and sympathetic nervous system firing, it causes vasodilation. And then just to understand the kind of compensatory mechanisms of the heart, and I think we're all fairly familiar with Frank Stalling law of the heart when we compare cardiac output to end diastolic volume or preload. So understanding that there's an increase in peripheral vascular constriction causing an increase in afterload, that then does cause an increase, causes the heart to compensate to try and maintain the cardiac output, remembering that heart rate and stroke volume equal your cardiac output. So to compensate, your myocytes will stretch and will stretch up until a point and compensate where and then at that point they cannot stretch any longer. That will then cause these backtracking pressures that I've mentioned. So first, an increase in afterload, causing an increase in your left ventricular pressures, causing an increase in your left atrial pressures, that then backtracks to your pulmonary capillary pressures. And if it persists, those then pulmonary capillary pressures will cause leaking fluid into the interstitium and the alveolar spaces of your lungs, causing the pulmonary edema that is typically so distressing in SCAPE. So how these patients will present to us is that it's dual well, they're two components. There's an underlying disease and then there's a trigger. So the underlying disease very often is chronic hypertension, especially with renal artery stenosis being a common component of this this hypertension. And as well as hypertension, there can be an element of chronic left ventricular failure, but specifically left ventricular, not so much biventricular or right ventricular. And then the trigger itself could range from an acute MI, a period of non-adherence to antihypertensives, drug ingestion, like any symptomatic intoxication, if there's significant exertion, stress, anxiety, if there's an element of sudden acute heart failure, like a valve dehiscence, or a sudden viral illness. And then there's I know I mentioned volume is not as important here, but of course it can, if there's any cause for a sudden increase in volume overload, for example, a patient missing their hemodialysis session or something like that, then that can cause an increased acute volume overload, which could precipitate a patient to spiral into a SCAPE type picture. On history, patients could present with a cough and pink frothy sputum, but also to remember that if they don't present with pink frothy sputum, it's not to say that this isn't SCAPE. It's not a hallmark feature. It's just a common feature. They usually have very significant and rapid onset of shortness of breath, difficulty breathing. It's very distressing. Their sympathetic nervous system is activated, causing them to be very sweaty, pale, unwell, agitated. They're usually quite combative, very difficult to reason, to talk to, can be difficult to manage in the ED. They may have had previous episodes of SCAPE, and then if you can get a history of recent triggers that can then support your differential diagnosis. On examination, the signs that you might come across, just as like a parallel to the history that I just mentioned, they have severe respiratory distress. That's usually within a short time frame, within 6 hours, significantly tachypneic, dyspneic. They're hypoxic on room air. Again, the sympathetic activation, kind of parallel what the history and symptoms would present. Diaphoresis, pallor, very unwell, very tachycardic, typically very hypertensive as well, with systolics well over 160. They can be even well over 200. And they can have diffuse inspiratory crepitations. That is representative of their pulmonary edema. So the two main investigations, once a patient is presented like this in your ED, that you want to consider, and primarily you want to consider point of care ultrasound of the lung, less so chest x-ray because that can take more time and it's not as sensitive as POCUS. So that's definitely secondary, but lung POCUS, and I'll show some images coming up, is very sensitive for cardiogenic pulmonary edema. So you'll have diffuse B lines throughout the lung fields with a thin pleural interface as opposed to a thick pleural interface, which can be a feature of other pulmonary pathology, such as ARDS, and they may have small bilateral pleural effusions. One can also do a quick heart POCUS, which usually has if the patient has pre-existing left ventricular failure, they may have features of that, left ventricular dilatation with a decreased ejection fraction and features of hypertrophy, more so left-sided than right-sided or congestive. But again, we always need to remember patients can present with dual pathologies. And then the fluid status is not as important. So if, this is quite a rapid deteriorating illness, you don't want to waste too much time. It's less important what their fluid status is. So I would focus on the lung and the heart POCUS. And then just for lung ultrasound, a kind of quick positions for your probes. This I thought was a decent image just to kind of give you a quick 1 to 8 areas to quickly check for pulmonary edema to screen for it. Understanding the difference between A lines and B lines. A lines good, representing air, B lines bad, representing kind of interstitial fluid accumulation of some kind. So these are two lung focuses just to compare cardiogenic pulmonary edema with quite obvious diffuse B lines. The arrows are pointing out the picture on the left with a thin pleural line, as opposed to picture B, which is typical of ARDS, which is the B lines or areas of consolidation are much more inhomogeneous. They're not as well delineated lines, and there's a very thick pleural line. So the beauty of lung POCUS is that it's quite specific. So one can quite confidently rule out cardiogenic pulmonary edema as a cause for patients' pathology if they don't have these diffuse B lines. So that's quite a nice, quick, if you see diffuse B lines, you can add that to your confidence in your differential diagnosis for SCAPE type presentation. Within reason, of course, because again, patients can come with dual pathologies and previous lung pathology that could obscure the picture. And then just quickly on the X-ray. So just looking for, if you do get an X-ray, just looking for features of pulmonary edema, so bilateral hilar infiltrates, your bat's wings appearance, curly B lines, pleural effusions. These are things one can look out for as well. In terms of the management, I liked how it's in most resources, I use the Internet Book of Critical Care, but they summarize it really well into 3 main points of management. It's positive pressure, blood pressure or afterload control, and close monitoring. And then adding to close monitoring, one can add titration as required, which I'll come to. So firstly, looking at the positive pressure, this is achieved with either CPAP or BiPAP. Both in studies have shown to be equally effective, but with BiPAP maybe coming out a little bit ahead of CPAP, and that is just more the patients tolerate it a little bit better. The perception of having slightly different pressures on inhalation and exhalation seems to create more comfort for patients, but both CPAP and BiPAP are reasonable to start with. Both ventilation settings will reduce your preload and afterload. And it's quite a rapid effect, and it's easily titratable with changing your PEEP and your inspiratory pressures. Your aim is to increase the mean airway pressure throughout a breath cycle, and the side effect of decreased cardiac output that we often worry about with CPAP and BiPAP is actually something we want in these cases. So starting points for CPAP and BiPAP I've listed there. You can refer back to that for details. But again, it's whatever point you do start at, and you can typically start quite high in these patients. The point is to be dynamic and titratable depending on the patient's response. The only limiting factor is the risk of gastric insufflation if you're ventilating with pressures more than 20 centimeters of water. So that is something to consider, obviously, because then that will gastric pressure will exert intrathoracic pressure on the lungs, further possibly like causing a detriment in their ventilation. So just something to be aware of. The other thing to be aware of is that mask discomfort and anxiety is a very real feature of CPAP and BiPAP, and it's very important to spend time, if you can, with the patient before placing the mask on their face, explaining the process. It is difficult though if they come in very distressed and usually quite combative. That's where there's a role for very light, gentle sedation or anxiolytics. Not so much benzos because of their we're less able to regulate their kind of respiratory depression effects, and you don't want to compromise any respiratory effort at all in these patients. Morphine and opiates are a reasonable option. There are studies to show, though, that there can be some negative effects, but again, these are studies in different settings, different contexts, not in South Africa. I have got these listed on my notes, which I'll send to Tammy, so if you guys want to refer. But I think in our setting, practically speaking, a low dose opioid, if you're monitoring the patient, if you're at their bedside, is a reasonable choice if it means that their mask anxiety is decreased. Just a quick image to compare BiPAP and CPAP. Essentially, the CPAP is one set pressure throughout inhalation and exhalation. BiPAP is 2 pressures that one can set. This comes from a website talking about obstructive sleep apnea, because they're often used as management in obstructive sleep apnea. And then just a quick graph, to kind of graphically represent what we're trying to do. So on the x-axis, you have time. On the y-axis, you have your airway pressures, your mean airway pressures. And if we're breathing spontaneously with no ventilation, our mean airway pressures essentially sit around 0. With CPAP, BiPAP, we're wanting to increase that to sitting higher, therefore decreasing your cardiac output, decreasing your afterload, decreasing the pulmonary congestion, and with the aim to break that cycle of SCAPE that I referred to in the beginning of the presentation. The second tenet of management is your blood pressure afterload control, and this has been shown to be most successfully managed with nitroglycerin infusions. So you want to aim for rapid reduction of the systolic blood pressure. So the Internet Book of Critical Care mentions at least reducing the systolic to 140. But again, I think that is to be taken in our own context and patient specific. So one can, I think, reasonably aim for a reduction of about 20% and an improvement in clinical condition, in like mentation and cooperation and that kind of thing. The nice thing about nitroglycerin is that it causes arterial vasodilation, and it also is very it has a short half-life, so it's easily titratable with a rapid response to whatever dose you're administering the infusion. There'll be a quick response to that dose as you go up or down. And patients are typically quite sensitive to nitroglycerin infusions, so they'll respond quickly if it's not a dual pathology that we're dealing with, SCAPE plus something else. So there is a loading dose and maintenance infusion. The loading dose, I didn't put in the numbers for sake of not cluttering the slide, but I do have them in my notes, in my annotations. But it's quite a high dose. It's 1,000 micrograms, as opposed to other situations you might use nitro bolus loading doses where you're talking in hundreds of micrograms. And we always concerned about the risk of hypertension with nitroglycerin because it is such a potent vasodilator. But in patients with SCAPE, it's unlikely, as they have such a profound vasoconstriction, that they need such a potent dose of nitroglycerin. Second line options, if even with the nitro at max doses, you're not adequately dropping the blood pressures, to consider IV calcium channel blockers. But this is something I would suggest initiating with advice from a colleague or a consultant, just because then there's quite a few means of dilating here, vasodilating with patients, and they need very close monitoring. The risk of rebound hypertension can be quite real. And that brings me, so then once you have your acute blood pressure after load control, you can consider your oral vasodilators. Again, you can, with the long-acting ones, you can consider starting them towards the tail end of the patient improving in the acute setting, and then kind of hoping for an overlap. But most cases, patients actually wean off the nitroglycerin successfully without having to start any antihypertensives, because the point is we've broken that spiral of SCAPE. That is what has been so pathological. So you break that spiral, the patient will settle. You can then consider stopping the positive pressure ventilation, the nitro, and then starting the oral antihypertensives to keep the blood pressure down, preventing that spiral from starting up again. So ACE inhibitors and angiotensin receptor blockers are good choices, just to consider though that their risk of nephrotoxicity in patients with pre-existing kidney impairment. If that is the case, hydralazine and isosorbide dinitrate produce a very similar effect without the nephrotoxicity, which is quite useful. And the third tenet of management is close monitoring and titration. So you want to ideally be at the patient's bedside, monitoring if they're responding to your treatment. And if they're not responding adequately, then it requires stopping and thinking. Perhaps there's a dual pathology, multiple pathologies, perhaps there's something one has missed. It's also second to that is because your blood pressure and resolution, if you have the correct diagnosis, will occur very quickly. You don't want to then push them over to the other end where they become hypotensive or their cardiac output decreases too much. So you've got to titrate quite quickly or quite prudently with your nitro and your positive pressure ventilation, but then also watch for recurrent SCAPE. There could be rebound spirals essentially that happen if you titrate it too quickly. And then while you're doing this, consider the triggers, because of course if we're not managing the triggers, we're not ultimately managing the cause. I've mentioned the long-term antihypertensives. Beta blockers are not a good idea because of their negative inotropy, and you don't want to impair the cardiac function any more than it already is, and it does worsen the pulmonary edema. Diuretics have also been considered, but are not typically routine because, again, this is not necessarily a volume overloaded state, but within reason, because we often, again, have patients with dual pathologies. And I mentioned the opioids before. In some schools of thought say no entirely, but I think, again, it is context and practitioner and, your nursing staff dependent. Kind of if the patient can be monitored really well, very closely, then there's no reason not to give them an opiate if it will ultimately assist with their anxiolysis. So the take-home points, that SCAPE is a bedside clinical diagnosis. It doesn't need long investigations waiting for hours. It's a rapid onset disease that needs to be kind of considered rapidly on their presentation to ED with history exam and POCUS. Once you've kind of decided that this is your differential diagnosis, it's a quick institution of therapy. If your diagnosis is correct, there should be a rapid improvement of therapy. If not, then this is something, like I said, we just need to stop, take a couple seconds to think if we've missed something or if there are a couple pathological processes going on. And again, it's a maldistribution of fluid, not necessarily an overloaded patient that will present, and it's an afterload specific pathology, not necessarily other components of cardiac output that are initially the problem. Afterload is your primary problem, and then it kind of backtracks into the other issues, the other components of cardiac output. Your management is CPAP, BiPAP, so positive pressure ventilation, and your nitroglycerin infusions. As I said, close monitoring and titration is important. Ideally, watching the patient with your own eyes, but it can get busy in our context. So again, managing your context, your patients, your ED, that's kind of relevant to the day or the setting is really important to consider as well. And that is it. These are my references. Thank you. Any questions?
Thank you, Andy. I really appreciate that you gave this talk again for us, especially while we are load shedding, etc. Are there any questions? Are there any comments? I think you're off the hook. Please, can you stop recording and remember to save to your computer? Thank you so much, Andy.